actually watching the youngsters sitting behind throughout my day, and I found that the most cheers and the most smiling faces which came were the last talk. I think we should all compliment him for his efforts. So it is actually the passion which is important, but more important, apart from passion, is your the way you do your work. And I think Sachin or someone did mention that though he's doing, again, he was doing it in a small center, but he was doing it ethically and legally. Why is it important today to talk about this? When I was a student and a resident, I'm very sure Dr. Kher will agree with me. We had no such, we had forensic medicine, but these things were not discussed. The relationship between the patient and the doctor was that of a paternalistic attitude. And I would implore each one of you, when you give your presentation, to give this disclaimer. If not now, an MC had to withdraw that act, but after some time, you will have to be totally transparent. And this is my first message to you. Whether you are being paid by a pharma or not, be transparent in your dealings. Be absolutely declare your interest. That is what differentiates us, our presentations, from the person who comes from abroad. He always takes money but gives a disclosure. So as I was saying, that the patient and the doctor relationship has changed now. Why has it changed? When I was a student, we used to look upon our teachers, and they were talking to a patient, and the patient will agree. I think, as we all agree, it is the corporatization, the Googleization, and your own colleagues, which has brought about this medical legal case. So again, things were discussed that a patient was given a steroids, and he did not respond, and went to the other nephrologist and said, "Oh, इसमें तो कोई indication ही नहीं था, genetic variety." So I think we need to be first. The second message which I want you to understand is, please do not criticize your own colleagues, or at least don't say bad about that in your, especially in front of your patients. So it's a very interesting or a very interlinked thing between patient care and medical negligence. Why is it important for us to discuss this? Because our first and foremost thing is patient safety. Now that should be always considered, and we want a very, very highly quality care to be prescribed to our patients, to have an also ethical angle attached to it. So, you are allowed, you can do a transplant in the third trimester if you have a passion and you're doing it ethically and legally. So I would like you to focus on this, because this is addressed to you, because this is the backbone of your medical negligence. So if you know what is the standard of care, no one expects you to be off the standard of Professor Kher or Dr. Chokha. You have to actually have a expertise which you should be able to deliver. That is standard of care. Important thing is informed consent. That is again a very, very important part of that. We'll try and discuss it further. Confidentiality and privacy. I think each and every one of us have this tendency to discuss our patients in our meetings. After some time, we'll start discussing, mere us PD ko ye ho gaya patient, that ho gaya, he's come to you. So that privacy has to be given to our patients. And documentation. Again, a very, very important part of our command. Now, of course, we have EMRs, but having spent 10 years in Delhi Medical Council, we realized that the most important thing which actually brings about a sort of professional neglect and medical negligence is your documentation. If you have not documented, you have not done, and you have erased the documentation. That is the worst part of it. So documentation becomes important. Of course, we need to be understanding our regulatory compliances. Every time we change, there are new, regulations which come up. We should be able to understand. We should also understand patients' right. We have to, like we are talking about PD, why is it 5%? Because we only tell 5% of patients. We do not empower them that there are 4 varieties of RRTs, and out of which one is no treatment as well. As of now, for an 85-year-old gentleman, if he has a good residual urine, we may not be able to, we may not like him to have a worse quality after dialysis. So that right should be given to the patient. And of course, we should always upgrade ourselves. Bombay Kidney Foundation has been doing to not only do a CME but professional conduct. So the numbers are increasing. I think the lawyers are also, like you have chosen this profession, the lawyers have chosen their profession, and their numbers are also increasing. So the number of medical negligence have suddenly shown a dramatic rise. I don't have a figure after 2016, but definitely the numbers are increasing. Why is it? Because of, again, as I said, now we have chat GPT, so the answer can come within seconds to a patient, and if you have not followed it, he will always come and complain to you. So what is required is the medical negligence is a lack of reasonable care and skill and willful negligence on the part of a doctor in the treatment of the patient. So this is very important, that there should not be any willful negligence. Now, negligence can be in the form of both act of omission, you have failed to do something, or act of commission. Now, but fortunately, at least, the onus lies on the patient or the subject to prove it. He has to prove that there was a duty towards the patient, the 4 Ds. There was a deficiency in duty. There was a damage which was the direct result of that particular lack of deficiency or lack of duty. And doctor's duty is very clearly, you can choose your patient. You can refuse to see a patient except in the emergency where one has to cater to the patient and take him to the next level of emergency. So if you are not able to justify these 4 duties, then you will not be given, the consumer will not be given any compensation. So what is the standard of care? There is a very, very clear-cut Supreme Court guideline on that. That is known as Boehm's test. Boehm's test is the healthcare professional is required to adhere to the standard of care which an ordinary doctor is supposed to adhere, and not of a very high skilled person. So even if you have been able to manage an ordinary care, that is enough for you to justify that this is what the standard of care is. Errors of judgment can occur. I think a 9mm stone may go to a urologist person and he'll say, I'll do a stone retrieval. Next day, only after Urimax, his stone passes, he saves. But then it was an error of judgment. Both alternatives were available. But if it is a 1.5 centimeter stone, and if I say it will pass, then it is my negligence. I should refer the case to a urologist for stone retrieval. So there are certain slight differences between the two, but we need to understand. But prima facie, the patient has to be able to prove in the initial stage that there was a error judgment, and then subsequently it comes back to us. These are some of the common causes. You must have heard that wrong anesthesia, wrong limb, wrong medication given, foreign objects being left in the especially among the surgeon colleagues. Many a times this after, I have seen one patient after 9 months having gone through 3 physicians with pain abdomen, and finally the gauze piece was taken out after 9 months. So these are certain things which are gross negligence, which we need to. And now we clearly know, despite of our having saying that medical profession does not come under consumer, but as of now, today, we are also a part of the Consumer Protection Act. So what are the liabilities? We need to understand. There are 3 important liabilities which we can undergo. First and the foremost, which is always in the back of mind, is the criminal liability. Now that criminal liability is a rarity. Unless a person is able to prove a gross negligence, then criminal liability does not ensue. And that too after proper procedure with the Supreme Court guideline being coming up. So more importantly, we have 2 types of other liabilities. One is the civil liability, which is governed by so-called, you have are deficient in your service, and the patient sues you for certain amount of money. And that is generally more towards the hospital, and the doctor is included in that. But more importantly, we are all, as professional colleagues, we are governed by our regulatory guidelines. NMC tried to bring out its guideline in 2023, which was from my side, it was a very, very robust guideline. It was very transparent guideline. But obviously, there were certain issues involved with that, and I would not have been coming here on the trip which was organized by the organizers if that would have been established. But I think still we need to understand it. We need to realize that in future some sort of a guideline will come. But that we are governed. And if I share my experiences with you in 10 years of Delhi Medical Council, most of the cases which were brought to the forum in the nephrology cases have been related to certain communication errors or documentations or not being properly communicated about the complications which occurred. So this disciplinary action is taken by a sort of a council. This is also a part of it. So we have our criminal liability, which is very, very rare. We have our civil liability. And how do we counteract that? We counteract that by joining hands with so-called the insurance agents. And now we know that Indian Society of Nephrology has joined hand with Cover You, and they will provide you with insurance coverage, liability coverage. And each one of you should at least take a coverage liability insurance of 1 CR, which comes at 2,500 or 3,000 rupees per month. So that coverage has to be taken by everyone. As I said, the criminal liability is one. So how are the legal remedies available to the Aam Aadmi or to the person? He can actually complain to the State Medical Council. He can also file a civil suit. He can file a criminal suit, and he can complain against a Consumer Protection Act. Civil courts are there. They will decide on the monetary liabilities. They are generally, lok adalats or there are other things. The sort of court cases go on and on. But more important, as I said, these are some of the examples where criminal liability can assure, though the cases cannot be proved, and hardly 1 or 2 cases have been there where the doctors have been punished, and it's a 304A, which results in 2 years of imprisonment or fine. But these are some gross negligence cases, performing a criminal abortion and operating on the wrong patient and the wrong site, wrong eyes. And I will also discuss one extra part which we nephrologists face as a criminal liability. Not face, but we may encounter if we cross our borders. That will be. But more importantly, I think disciplinary action. We all know that each one of the doctor who wants to practice has to register with the state council, and the state councils have the authority to take disciplinary measures, and that includes warning to the suspension. Now, 10 years we tried our best to establish the quantum of punishment. How do we decide that this professional neglect gets 1 month of 1 month of patient being not allowed to see? On the other hand, the other person gets 3 months of this thing. So now again, the new guidelines in NMC had brought out clear-cut guidelines on how to identify or quantify the quantum of disciplinary action which we need to take. So we all know the consumer can file the complaint, or there are now recognized associations, a central or a state government. All of them, there can be a suo motu action against a doctor by the courts as well. And what are the steps involved? They can file it with a local police or state medical council. If it is appropriate, as I said, the council can start taking an action against you directly. If the case is criminal, it will be state versus the doctor, and of course you can have the various stages where the judgment can be appealed to the medical council. The consumer courts are actually only meant to seek monetary compensation, which can go up to 3 levels. So these are the 3 levels. If a person is having a civil liability of 20 lakhs up to, he will have to approach the district forum. The state commission has the limit of 1 CR, and if there has been a liability of more than 1 CR, we have to approach a national commission. And you must have heard the place where you are sitting, Calcutta. There was a case against a famous rheumatologist where, I don't want to name that how many crores were liable, just because, unfortunately, the person who was fighting the case on the other side was an NRI doctor, and he knew about the intricacies of diagnosis and complications. So this can be. So how can we protect ourselves? I think it's very important for us to now understand that medico legal, you do your transplant, you do your dialysis, you are doing everything, but patient is important for you. You have to respect him. You have to communicate to them well. You have to empower them. You have to take their informed consent, which are all very, very important components which we unfortunately neglect. Having worked for 20 years in government hospital and then 10 years in private, I try to establish the consenting process during dialysis. Tell me how many of you take the consent from your patients every time when the patient comes for dialysis? I don't think anyone takes, or maybe one or two hands have come up. But these are certain important things which we need to look at the quality of payment. A doctor can also protect itself. He can appeal against some of these laws which are in favor of doctor. I'll not go into details, but most important, as I said, documentation. Now, it is extremely important whether you are following electronic medical records or whether you are doing it, writing it by hands. Documentation is what which will protect you. If you have not documented, if you have not done, if you have done a procedure, if you have given certain medications, it has to be, so a good record will produce a good defense, and no record or poor record will produce a poor defense. This is where we lack. We unfortunately sometimes try to fudge or overwrite it, where the judges take a very severe action, but it is extremely important that documentation process has to be. Now, there has to be a format of your prescription. Fortunately, when you start practicing, you have your colleagues, or at least in the pharma industry, which are providing you with softwares to write your prescription. But again, an MC has come out with the format of prescription which you must. In our times, I still know the doctors, you can't even see the handwriting, you can't even make out, except the chemist who's able to recognize that hand, and they don't write the name, they don't write the diagnosis, they don't write the investigations, but this is the format which you should use when writing a prescription as given by the NMC guidelines. Now, more important is informed consent. Gone are the days when the paper was handed over to them, the patients, and they would sign it. No. Informed means that they should be totally empowered. They should be empowered that dialysis is being done, why hemodialysis is being done, what are the other alternatives available. Is peritoneal dialysis also a modality? Is kidney transplant in Kolhapur is also a possibility? And not doing anything is also a possibility as per the international guidelines. I don't know whether we have followed it or not. So all these possibilities have to be given, and for hemodialysis, what complications we are likely to see has to be mentioned, and we should allow him to refuse, I don't want to do PD, rather than not telling him of not doing a PD. So these are very important things, and if we fail to obtain consent, and many of times the civil liabilities have come, because there are certain emergency situations where you may not have the time, or the patient may not be conscious enough to give you a consent, but overall the consenting process has to be there. And this is again, someone of you had asked me whether you have any criteria or any format of informed consent. Most of the corporate hospital has. I had prepared this, so you can take the slides after that, and you can see what components should be there in the informed consent form. And third important thing, councils are very strict regarding issue of now young generation have the tendency advise rest for 3 months. Patients on dialysis rest for 3 months, okay. But no, there are guidelines. You have to be following your council's guideline, not more than 2 weeks at any point of time. And if you have to give rest for more than 4 weeks or 2 weeks, you have to justify it. You have to mention this patient is a post-transplant patient, attending his office would be detrimental for his health. That is why I'm issuing up. Otherwise, many times we also in council cases have come up which could have been genuine but not documented and not justified. They were penalized for this. So there are certain duties. We have to be truth-telling. We have to tell them that what are the side effects, what are the complications which can occur. We have to also, we can choose our patients. We can refuse to see our patients. But we should also not hesitate to take an opinion. There's no harm in taking an opinion from the second nephrologist. When I was in Max, 3 important things which we used to do. Call any other doctor if you want to show. You want a document, you please take the document. And if you want me to communicate with your family member doctor, patient advocacy is coming up. Last 9 months I've been in USA. I am not allowed to practice there because I don't have but patient advocacy. I talk on behalf of my patients, and they talk to me for half an hour. So now this profession is also coming up in a big way. Many doctors are now taking up this patient advocacy, in which you talk on behalf of patients. So these are certain important things. And of course, there are now guidelines for telemedicine consultation, which is again, DMC has come out with. there are very clear-cut guidelines. Unfortunately, it is all virtual. We cannot touch the patient, we cannot examine, but there are certain gadgets which have come up to do that. Well, there are certain cases, these are hypothetical cases, but please understand that these are the situations which you can come across, especially the younger generation about this. So this was a patient of chronic kidney disease. He presented to the emergency department. The duty doctor, without informing the patient or the attendant, decided that, he has a potassium of 7 and acidosis is there. So I am going to dialyze. Straight away took the patient for dialysis and started doing a dialysis. Well, there was no proper communication and informed consenting form was there. So now this was in a hurry. This happens in a hurry. When you have a sick patient, you say, but unfortunately, you have to talk to your family members. You have to tell them, why is it important for us to do the procedure? Now that is a win. Well, in emergency situations, you may justify that there was no time for me to take a consent. In that case, you have to document that I will be taking the consent later on because it has become a life-threatening situation. This is again an important thing, and this I did a poll because there is no guideline on that. The first year resident had joined, a fellow had joined. He was very enthusiastic. He wanted to do a kidney biopsy, and the third year resident was there, and the patient started having bleeding next day morning, and there was a big hematoma formed around the kidney region. So now, what is the guideline? There was no clear-cut guidelines. Only 2 places it is mentioned that a minimum requirement of 5 native or 2 transplant biopsies and simulation training under real-time ultrasound. This is it's given by one of the American boards, and the Australia says that 6 native kidney. So please look at the kidney biopsies first before jumping on to doing it yourself unsupervised. Do a supervised kidney biopsy because you may anyone can end up with hematuria, gross hematuria, hematoma. But this is again one case where we can get caught if we do not, get adequate skills to do a certain procedures. Well, this is what I was referring to. There is, apart from the other criminal liabilities, we have our own Human Organ Transplant Act. Unfortunately, we cross boundaries, so that is why we get caught. And I know there have been case reports, no one has been implicated, but then just because there are authorization committees, doctors should stay, nephrologists should stay away from deciding who will be the donor. You can empower them, you can counsel them, but please do not participate in that process. There is a hospital authorization committee, there is a state authorization committee. Let them decide, and when they bring to you, we only look at the technical aspects. And this is again a very, though there are some controversial things in this as well, but this also gives us a lot of stress, and this thing where the doctors have come in the media much more. Again, there are certain complications which can occur, and these complications, if not discussed earlier, you can go into issues like this patient had a transplant done, but he was unfortunately not tested for CME, and within 2 weeks the CME came up and there were some issues with that. And you not being able to make a diagnosis because of your inadequate knowledge. Now that is where comes this thing of referral. If you are a third-year resident and your consultant is there, you are not sure about the diagnosis, you can always, I had this instance where the patient had come to me with a leukocytoclastic vasculitis, and his ANA was positive, dsDNA was positive. I started the patient on steroids. She started, then she did not respond. I put her on MMF. She started having diarrhea, and unfortunately, she was lost to my follow-up. After 3 months, she landed up with Dr. Narendra Hospital, where they did a biopsy, and they found AFB on bone marrow. So obviously, now there is a lack. You see, the issue is that whether tuberculosis came up after or before, but I relied on the reports of the labs which were available outside, which were from a very standard labs. So there are certain things which sometimes can occur, but one has to be very careful. There is a need for you to empower your patients about the alternative. And the last slide is the 6 C's. You have to be very careful. This is your preventive strategy. Checklist, always make a checklist. Whatever you're doing, you have to involve the patient as far as cost is concerned. Always rely on consenting. Do counseling as much as possible. Talk to them about the disease, talk to them about AV fistula formation, why is it important, and you should, complications will occur, but manage them properly rather than leaving them alone, and always get covered yourself with 1 CR, minimum 1 CR insurance. Thank you very much for your patience. And if there are any questions,
I think the best line was to cover yourself with minimum 1 CR. Yeah, more than 1 CR is actually